Yeah, we can hear you.
Okay, perfect. Yeah, let's wait for a few more people to join in and then we'll start, okay? Let's give it 5 minutes, I think, because a few people asked to present and I can see that Iram Shahani is here. There were 3 others. Hello. Yeah.
Assalamualaikum, doctor.
Walaikum assalam. How are you?
I'm good. How are you?
I'm good. Thank you. Ready to present, yeah?
Yeah, sure, doctor.
Okay, yeah. We'll wait for 5 minutes. Yeah. So we'll wait for 5 minutes so that other people can also join in and then we'll start, okay? Okay, I think we can actually crack on. Okay, so it will obviously take a little while to start as well. Can you see my screen?
Yes, doctor.
Okay. Okay, so let's start, I think. Yeah. Okay. So you're the first start, I think. Yeah. Okay. So you're the first one to present, Iram, right?
Sure, doctor.
Okay. Yeah. So I am just going to show you something and then we'll take it from there. So your scenario will start now. Okay, you can ask me to scroll up and down and whatever you want me to do. Can you see it?
No, doctor, I cannot see it properly. There's so many screen over here. It is divided in portion. I cannot see exactly my task.
Okay. Okay, just trying to figure out what can I do because I think that I'm sharing my screen.
Actually, it is showing the participants as well.
It's so okay.
Yeah.
Okay, can you see this? Can you see the screen?
Doctor, I cannot see it. I can see the screen, but I cannot see it properly. Can you enlarge it for me?
Oh, yeah. Okay. Yeah, sure. Is it big enough now?
Yeah, it is.
Okay, right. I can scroll here and there whenever you want, okay? Should I scroll down?
Yeah, doctor.
Okay, so we can start your time now, okay? Take your time, don't worry. We are practicing, but we'll try to do it in 2 minutes, but it's okay. We can give you an extra minute. That's fine. Okay?
Yeah, sure.
Is it okay, Ram?
Sure, doctor.
You're looking at it, right?
I am. Doctor, please a bit slow.
Okay. I can go. Yeah. Okay, going back.
Okay, sure.
Okay. it okay if I make it smaller so that you can see the whole picture?
Doctor, the picture is already very small. I am unable to figure this out
You
properly.
are watching on your mobile.
Yeah,
Probably
yeah,
that's the reason.
yeah.
Okay, so what I can do is I'll try to send it to you. If I can. Let me share it in the on Telegram with you.
Hmm.
Okay. Now you can have a look at it in a minute, okay? And then we'll start speaking about this. For everyone else, I'm just making it smaller here. Okay, Rama, are you happy to start?
I'm not happy, but yes, I can start.
You have to be
Because
happy.
doctor, this is so much.
In exam is, we won't be happy, but we have to. Yeah, okay. Just in a second, I'll start the first question. Okay, so it's fine. We can start your time now.
Okay, doctor.
Right. So what is this document?
This is an audit of labor ward showing the maternity unit in which these were the babies born in 9,375 per year in 750 months. The scheduled bookings and induction and spontaneous vaginal births for which will ended up in cesarean section, forceps ventouse, and emergency and elective cesarean sections. What is the target range and what were there in the September 2021?
Okay.
And what are the indicators of it that is shown in red flag?
Okay.
I just see these three things and year
Yeah.
to date and variable narrative for most recent one data.
Okay. Yeah. Yeah, that's fine. So can you think of any other name for this document?
Audit, doctor, we can say, like it's an audit done on a maternity ward.
Okay. Yeah. Okay. So what do you think are the uses of this document?
Yeah, this give us an indication that what were the I mean no what were our references through which it's a comparison. So uh, it can indicate that how many we deviated from the landmarks which were there, which they have set the targeted you can say benchmarks which have been set. So if the deviation is there, what was the reasons behind? So that overall will give you the quality and the protocols which we follow in any department. For example, if we talk about this one.
Okay. Okay. So can you tell what are the salient features? Because now you have got the whole document with you. You can scroll
Yeah,
it up
yeah.
and down and have a look. I'm just helping you, examiner won't. So you can scroll up and down and see, yeah, because the document will be there in front of you. Yeah. So take your time.
Okay, okay.
What are the fit? My question is, what are the salient features of this document?
It's a chart in which the activity is on this right side of this document, and then it has been divided in the target levels and what are the red flags indicators. These are the indicators, and then yeah, uh, the percentage is given in this.
Okay.
The what workforce we had, people involved in all these procedures, and what were the now I can see morbidity, maternal mortality and morbidity, maternal morbidity, in which it is division in a PPH, ICU admissions, about maternal deaths, which were early, maternal late, and then perinatal morbidity and mortality, number of stillbirths, hypothalamic ischemic injuries, shoulder dystocias, unexpected NICU admissions, then readmissions and maternity safety, test endorsements, public health. These all indicators you are talking about?
Yeah. So you have to tell me what are the salient features in this document. Yeah. So that was the question.
Yeah.
Okay. So what do you think
So
are the advantages
these
and
are the indicators, and what are hello?
Yeah. Yeah, that's fine.
Hello?
Yeah. Should I go ahead for the next question? Are you done with this one?
Yeah.
Okay. So
Yeah, sure, doctor.
what do you think are the advantages and disadvantages of this document?
Yeah, the advantages is that this it in a just single look it gives uh, how our maternity unit or anything is functioning. Like, is it up to the mark according to the set protocols, according to the benchmark? It gives the idea in just a one single look. And where if it is deviating from any like benchmark, then we can have a look on this, that what is the reason behind, is there any task force which is any of the component is missing which resulted in that. And it gives an idea of any of the department, that how's it's functioning. It can shows like if the morbidity and mortality is too much, what's the reason behind, if it's deviating from this path. So these all could be seen in a one go. Any unit, how it is working, how it can be made better. So we can see it in one go. Where are the areas which can, if we make amendments, and which can, the improvements we can, areas of improvements we can pick on this.
Okay. Yeah. And what are the disadvantages of this document?
Disadvantages, details cannot be retrieved in this single document, and what was exactly the cause, like reason behind whether the morbidity or mortality whatsoever it was because of any specific reason that cannot be found out exactly in the it just gives a number, that these are the numbers. And drawback, any other,
Okay. Okay.
this is what
So
I just think of.
okay. Yeah. So what do you note on this document, that what are the things that are out of the target, which are above the
Can
target?
we go back again? Yeah, can we go back again?
You have got the document now. Yes. So you can have.
I just see this question only, nothing else.
No, you've got the document in your Telegram. I sent you a message.
Doctor, I cannot see over there. I have checked it. So
Okay.
that's why I was following this. Yeah, so
Okay.
sorry.
No, it's fine. Because I thought that it will be easier for you to have a look at that.
No, it was not there, but I thought it's okay.
Okay, right.
Yeah,
Okay.
that's,
Yeah. So can you see the screen?
yeah. Now I can. It
Okay.
shows that the target level of target number is less percentage of cesarean section is less than 26%. But in September it was 32%.
Mm-hmm.
And
Okay.
yeah. So anything which crosses 26 or more than that, yeah, now I can see. Thank you so much. Yeah, if anything crosses more than 26, it's a high alert. So it is also one of the indicators that it is showing that it is more than 32%. It means it may need to have a look why this rate is on a higher side. Like it's 80, yeah. So maybe the reason could be the induction is there must be an undue induction, or what are the indicators on which this rate is on a higher side. So that may need to be reviewed.
Hmm. Okay.
So I cannot see any indication over here.
Okay. Anything else you can see here?
Shoulder dystocia is less than 1.5%, but this shows it's 1.3%, and NICU admissions 4%, and reflex 6. It shows 18%. So this is also a bit on higher side.
Anything else?
Hospital thrombosis target is 0, and it is also 2.
Okay.
So these all indicators show number of SIRI is on, I cannot see over here. So these also are sort of indicators which show that the number is outranging, and what's the reason behind that, that may need to be evaluated.
Okay. Okay, so because you said that the cesarean section rate is high, so what do you think should be done about that?
Again, details regarding that may need to be seen. What's the reason? What is the indications for cesarean section? That may need to be reviewed. Is there any particular uh, personals involved in that? Because few people have the low threshold for cesarean section. Whether there is any issues in the judgments, because at times few people on CTG, they take early decisions, and as you get experience, as with the passage of time you get more knowledge, your decisions get revised. This is what we have seen in our practice, and this is what it has been seen. And then at times what is the indications that may need to be reviewed. At times what was the cause of induction of labor, because as induction of labors end up in emergency cesareans, so these things all may need to be reviewed. So as to get this to the landmark, like that's a benchmark. I mean, that is 26, 1 out of 4 women need cesarean section. So that can give a better idea about how we can decrease it. We can review the policies, trust policies, and then have a discussion, have a look, have a detailed, I mean, analysis. That at times, I guess, root analysis is because of some, I guess, untoward or any morbidity maybe. So that may needs to be evaluated properly. That what's the reason behind. So in that way, new protocols may need to be made, and again, then re-audit need to be done.
Okay.
So as to see that what are the, yeah.
Okay.
Okay.
All right.
Thank you so much. Thank you very much.
Thanks. Thanks a lot for coming up here. Okay. So any comments? Just in a second, I want to see who is there so that I can ask one of you guys to who wants to give? Noreen, do you want to give a feedback? Iram, you can mute yourself. Thank you. Noreen, are you there? Maybe she's not there. Anybody wants to give a feedback to Iram?
Hello?
Anybody wants to give a feedback to Iram?
Hello, can you hear me?
Yeah, I can hear you now. Yeah. Do you want
Hi,
to
Dr.
give a...
Mara.
Hi, how are you?
I'm good.
Did you,
yeah.
did you attend the session from the start? Yeah.
Not completely, but yeah,
you know what
I was able to, yeah. First of all, the good thing regarding the Iram, her pace, confidence, and she's very good in flow. She picked up, but she was saying about the audit. So she should tell the buzzword of the maternity dashboard, that this is a maternity dashboard, it's a benchmark tool, and it will assess the hospital performance against the standards that is set, like RCOG's guidelines, on a monthly basis. And by this, we can identify the issues and we can act promptly to avoid what can happen, the consequences. So otherwise, she's trying to, sorry, I was walking fastly. So, she identified many things, and she talked about the salient features also, but she should have told in details a little bit, like what are her clinical activity and workforce and outcome and patient perceptions, what are the, basically these are the salient features. And regarding the, we know that these are the green, amber, and the red. So she tried good actually, and she did. It can be a little bit more better, but I think she tried well. And yes, thank you.
What do you think about your task yourself?
Hello.
Hi, Iram, are you there?
Yeah, Dr. Amara, actually, to be very honest, when I saw the dashboard, this slipped in my mind and I thought to ask you, doctor, I cannot do that because it was really, suddenly when I saw it, I'm like, oh my God, seriously. And the screen issues and all that. And I'm like, I shall quit. It's better not to do or do it in a bad way. But I thought, okay, it's okay. I'll fail. Now it's okay. So I just took it and got it forward.
Yeah, so it's not an exam. So the important thing at this stage is to come up and to present. And obviously, this is why I brought this maternity dashboard, because this is how the dashboard looks like. The dashboard actually doesn't look like what you Google and you see the images. So this is what the dashboard looks like. And you may be given a document in exam which you are not familiar with. And actually, you know everything about that. But since you don't know that this is how the maternity dashboard looks like. So when I was preparing for exams, so, as we always talk, me and Munazza tell you that because obviously we also took our exam as overseas candidates, and we were not also familiar with the system. So this is how you learn. I mean, you are struggling with the things that you don't know, isn't it? So these are the documents.
It was like that, exactly. And when I saw it, I'm like, oh my God, why I joined the meeting in a first instance? Because literally it was all shattered. And I'm like, I was about to say it's a maternity dashboard, but again, then I'm like, okay, exam will be like this. So it's okay, go for it.
Yeah,
Thank you so much. Thank you so much.
That's fine. Yeah, so the thing is that this is maternity dashboard, yeah. And so in exam, you may sometimes get some documents which you are not familiar with. So as you started that you started to read that document, then it comes up in your mind that yes, probably this is a maternity dashboard, and then you start recalling the things, and then you can pick up. Yeah. So as you can see on the screen, that let me show you again. I can actually enlarge it for you a little bit. Yeah. So this is a hypothetical one, not a real one, but this is exactly what the maternity dashboard is. And this is how it is presented in the clinical governance meeting. Okay, so this is the target that you have identified. This is a maternity dashboard. This is the target. So this all through till the end, this yellow bit is the target. Okay, and then now you can see that there are other months as well. Okay, so what will be done that every month these will be filled, and then obviously we will see in terms of comparison that if it was red here, then is there any betterment after discussion in the maternity clinical governance meeting? Okay, what were the steps taken when it was red? What was done when it was amber? Okay, when it's amber, and we know that this is the target, that 625 births per month is the target, and when it's above that range, so problems can happen. Okay, and then if you scroll down, obviously green is within normal range. This is red. Red is not very red, it's kind of pink. Okay, but we know that this is red, and this needs an immediate action. And then for cesarean sections, obviously, as you said, we will. They have what they do is they present in the meeting. So the midwives, who are the clinical governance midwives, they do all this bit. It's just like, I remember when I was working in PIMS, we had a monthly meeting, and we discussed the statistics in a similar way, but that was not called a maternity dashboard. So it's a similar thing. So every unit has got some of the tools to look at their performance. So this is one of the tools which the NHS uses to look at their performance. This kind of dashboard is used in other departments as well, but in maternity we call it as maternity dashboard. So we can see that the C-section rate is high. So if you start reading things, it becomes easy for you. So emergency were 18%, elective 12%. Okay, so now you scroll down again, midwives, midwifery birth ratio. So that was also a bit on the higher side. More women delivered because there were less midwives, so less staffing. And then it's all green, so we can skip that bit. So green is met. So let's go down to the next one. So there was a one case of HI3. So what were the reasons? So there is some comment here that it's under investigation. Okay, so another thing is that this is also a red bit, so that needs some attention. So you need to pay attention to the amber and the red bit. Okay, and then obviously the examiner will just keep on asking, this is what happened. So this is just to give you an idea that then if it happens, then what is the next step? Okay, so a discussion is done regarding that case, and then they make a plan that was it avoidable. So now you can, if I scroll back, you can see that we can compare the other months as well. Yeah, can you guys see what I'm showing you? Hello.
Yes, doctor.
Okay, perfect. Okay, yeah, so that's maternity dashboard. Okay, so it's all from the RCOG document. We know that it's a tool to monitor the implementation of principles of clinical governance on the ground. Okay, and as you said that it is used to benchmark the activity. We have got nationally agreed targets beyond which, if, for example, the cesarean section rate, agreed section rate is 26%, then 32% or even 28% will be higher. So then the department will see whether we are in the amber range or we are in the red range, and what we need to do about that. It's just like a car dashboard, which gives us the contemporary information about the amount of fuel and state of battery and everything, so that we can plan ahead. We can plan our journey before leaving our home. Okay, so it's just the same thing. And it tells us about the resources, that is the midwifery staffing, medical staffing, yeah, stuff like that, bank staff and everything. I'll tell you that later as well. Clinical activity, how many deliveries and how many home births, and cesarean sections, instrumental births, third-degree tears, PPHs, any untoward events, any series, which are the serious incidents requiring investigation, yeah, and stuff like that, so that we can identify early, and a plan can be made ahead to for better performance of the unit later on. As you said that it's amber, green, and red, green, red, and amber. When it's green, it means that the goals are met, and obviously that's very satisfactory, but still we have to maintain that. So if it comes in the amber range, when the goals are not met, they are above the lower threshold, but it needs some attention and action at that stage before it goes into the red area. And when it's red, then obviously it's worrying, and then immediate action needs to be done. Okay, and another important thing, sometimes the examiners do ask the questions because you couldn't identify the document, so that's why I didn't ask you. Are these parameters dynamic, or they are constant? So they are dynamic. So every unit can change the parameters accordingly. Okay. For example, if it's a hospital based, as I showed you, so it's different. So if it's a community or a midwifery-led unit based, so they will not have the cesarean section. They can mention like pool births, number of pool births, number of home births, and number of third-degree tears or second-degree tears or PPHs. So they can change it depending upon their own circumstances. So that can be changed. Okay, and the salient features we have discussed, that the clinical activity, you can see on the side that there is a clinical activity, then workforce, and then clinical outcomes, risks, incidents, complaints, or patient satisfaction items on that as well. Okay, in the high-risk unit, for example, in terms of clinical activity, the number of antenatal bookings each month we saw on the top of that, number of deliveries, then cesarean sections, instrumental delivery, and so on. And in the low-risk midwifery-led units, number of deliveries, women transferred in labor, for what reason they were transferred, was it CTG, or was it delay in progress, okay, or meconium, or abruption, or any other thing. So everything will be noted down whenever they are transferred. But this document will not give you a lot of information. It will be in the meeting that everything will be discussed, okay? Especially if there is, for example, like hospital-based thrombosis. So what were the reasons? So they will dig into that then. But this is just a tool that gives you an indication that something is happening that needs attention. Okay? Are you guys getting my point? If you have any questions,
Yes, doctor.
And okay? And
Clear.
yeah, and for the low-risk midwifery-led unit as well, as you can see, sometimes if the number of the deliveries is more than what you expect, then units need to be closed. So even those things are also addressed, okay? And in terms of workforce, it mentions the midwifery and obstetric staffing, as you could see, the number of the midwives to patient ratio, okay? And that also includes the staff sickness levels, and obviously that gives us an idea that, you know, if people go off sick, who will be covering them? Is there any bank staff, any extra staff? And also in terms of their training requirements, so everything is taken into account, okay? And yeah, so basically this is it, and you don't need to go into a lot of detail about that, because the questions you will have will be either about an increased cesarean section rate, increased risk of third and fourth degree tears, and instrumental deliveries, and PPA, something like that, okay? So we'll come to that. And as we have already seen, but the clinical outcome indicators on this are eclampsia, major obstetric hemorrhage, blood transfusions, anything significant that happens. And in terms of neonatal morbidity, meconium, aspiration, HIE, and expected admission of term babies to the units, okay? And if there are any patient complaints, obviously if the number of deliveries is above the range and there is less staffing, there is expected to be more number of complaints. So these are also information of that is also there on the maternity dashboard. So who should have access? All maternity staff can have access to the maternity dashboard. There is a clinical governance meeting every month, and then invitation is sent to absolutely everyone related to maternity, all community midwives, all midwives working in the hospital, and all trainees in that deanery, and the consultants, and everybody working in obstetrics. So everyone can attend that meeting so that they are on board with whatever is going on in the unit. Okay. Actions we have already discussed. If it's red in amber, then, and if it's related to staffing issues, if it's related to the midwifery staffing issues, then to the lead midwife, midwifery manager. And if it's related to the doctors, and obviously then to the doctor's rota coordinator. Okay, if there is any resourcing issues, then to the business manager, the trust people. And if there are more patient complaints, then obviously root cause analysis is done by the clinical governance team. And that's a separate discussion, so we can have some scenarios related to that later on. Increase in number of cesarean sections, as we discussed, that would require an input from the obstetric team. As you said rightly, that we will see how many cesarean sections were done as an emergency, how many as elective. For example, for emergency cesarean section, what were the indications? For example, if people are doing more cesarean sections for fetal distress, then you know, the team can look into the reasons why it was decided to be a fetal distress, and was there an appropriate indication. And in terms of individuals as well, like if, for example, when there is a switch over time of the trainees, new trainees come, then sometimes these things can happen that before they are adequately trained, then there can be an increase in such things, yeah. And so then it's looked into whether staff needs some more training, yeah. So what were the reasons that it was decided that it was a fetal distress? was it justified or not? And then if it's elective cesarean sections, if more cesarean sections were done for breech, were the women offered ECV, or they were offered vaginal breech delivery, things like that. So these are the things that we can do to reduce the number of cesarean sections. So there are many other things that you can think of how we can reduce the number of cesarean sections in units, and also counseling women for VBAC. Yeah. And then educational supervisor and quality tutors may need to be involved if there are some problems with the training. Okay, if it's amber, that repeated entry into the amber zone may lead to obviously later on entry into the red zone. And yeah, for example, as we have seen that a higher number of antenatal bookings suggest that the system is under strain. So it is possible that the mistakes will happen later on, or there will be problems later on. So an adequate staffing is required, or the women need to be referred elsewhere. In case of red, obviously very close scrutiny and immediate action and intervention. So there are some examples that red in Erb's palsy, secondary to shoulder dystocia, may require review of the cases to identify any training needs and who were the women, were they diabetic, were they screened properly for diabetes, yeah, and were they given an option of cesarean section at that stage or not, and what were the fetal outcome, and what were the maneuvers used for shoulder dystocia, were they conducted properly or not, is the staff trained adequately or not. Okay. And a red for failed instrumental delivery in room, for example, forceps applied but didn't deliver, then ended up in a cesarean section, then it shouldn't happen, obviously, ideally. So then was the decision okay to deliver in room, and then training needs and stuff like that is again looked into. And similarly for HIE, whether some training regarding the intrapartum fetal monitoring should be done or not. Okay. So advantages are that it improves the overall quality of care by informing the healthcare providers their performance, and it helps to understand how processes for delivering healthcare services are designed to meet patient quality and operational requirements. It seems to be a bit complicated, but this is all what we have already discussed. Okay. So just make it simple, and if you tell examiner whatever you understand in your own words, it's totally fine. Okay. Disadvantage is that it can just be another paper exercise if action is not taken. So it's very important to identify your own unit's needs and to modify the maternity dashboard to suit your local needs. Okay. For example, if in your unit you think that there is something which is different from what is discussed here, then we can add something else. For example, I couldn't see the third and the fourth degree perineal tears, so that can be added if they are like, for example, in a hospital-based unit where there are more instrumental deliveries, so there is a risk, so that can be added. And in terms of exam questions, what you can have when you have a maternity dashboard, if there is a number of failed instrumental deliveries, so that can be one question, or obstetric anal sphincter injury. Okay, then you see whether it's a one-off, only in a month, it just happened once, or it's persistently happening. If it's persistently happening, then obviously there is training issue. Yeah, so these are the things that needs to be looked into. And then how to fix it at individual level, as we discussed, that to address the training needs, and institutional level to offer more trainings to the groups of people who are working there, and check whether appropriate case selection was there, people were trained of repetition. Okay, and we have already discussed the high cesarean section rate here. Okay, yeah, so that's it basically. Munaza, do you want to add something?
First of all, I will just appreciate Iram that she has gone through it. It was under breakdown. Okay, what has just come out as a maternity dashboard. But it do come in the exam, and this is the key for passing the exam, that you have to keep control of your nerves when something comes out of the way, and you just describe or do that station as it comes to your mind, because we all have theoretical knowledge. That's why you have passed part 2, and now you just need to keep yourself calm, understand that what examiner want to listen from you, and utilize your 10 minutes in a very effective way. So covering the whole dashboard might be a challenge in these 10 minutes, but you should be aware of some basic things, that examiner has his own set of questions for which you will be marked. And obviously you have to give the answer in a very short and succinct way so that you get the required numbers as well. Whenever the dashboard comes, it's important that you describe the definition of this dashboard, that it is it is a tool that we use in clinical governance and risk management and determine the activity going on the floor. This is the definition. You have to just tell the examiner that you know and you grasp that it is a maternity dashboard. Thereafter, you start that how you are going to get the marks. Okay, so the marks are on the buzzwords. And these buzzwords are like, we are monitoring the performance. These are the key performance indicator or KPIs. And we are monitoring our outcomes, activities, and what does amber, green, and red means, which Amara has told you in detail. The thing is that all the maternity dashboard that comes in exam, they do have one red activity that is going on, and what they want is to highlight that activity and see that how you are going to cover this red activity and make management according to the red activity, that how we reduce the having a high cesarean section rate in that month, and what actions you are going to take. And this goes in combination with audit. So you can then, for example, if it is a cesarean section rate that is increased on that particular month, then you can start that how you are going to take actions to reduce this cesarean section rate. Particularly in exam situation, they will usually give you only one red indicator that is high, and you will then going to address that, and they will assess that whether you are going to transfer this into the action of having an audit done, QAP done, or what actions you are going to take and how you are going to disseminate that this is a red outcome that need attention of the whole department. Otherwise, when you are going in exam situation, how Iram did was quite well, only need a bit of polishing, and the courage she showed going through the station was really appreciable. I would suggest that only a bit of things and polishing of these skills to go through the exams will let you pass this station. The other thing is that examiner have usually 4 or 5 questions. So just finish your talk within 2 to 3 minutes whenever you are answering one question, and wait for the examiner, that whether examiner asks you another question or not. If examiner has question, he will obviously ask you. But if he don't have any question, give a pause and then start on whatever you know about the dashboard or what you ever have the knowledge of this. And last 1 minute in any scenario like this should be summarizing your dashboard. So keep the summary of this dashboard in last 1 minute, so that either you will summarize your own station, or the examiner, if there is any pending question or anything, he will, because examiner are trying to let you pass, so they will ask you that, okay, there is one more question left, let's ask about this. So try to do this station in this way. It will help you to get more numbers when you are going to have it in an actual situation. So this is my feedback for this.
Thank you, Manilda. Another thing that why I chose this document is because I have seen many maternity dashboard images, I would say, not the proper ones. So they are not what it actually looks like, and it's just to give you guys a taste of what you can expect in exam. Yeah, so you can have things which you are not familiar with, but that is something that you know. So just have a look. Think in your mind, as Manilda said, that just control your nerves for a minute and then you will do it. Yeah, well done. Thank you, Iram.
Thank you so much, Dr. Munazza and Dr. Amara, for giving me the chance and giving such a brainstormer session. Thank you very much.
Welcome. Thank you. Okay. Munazza, you want to take the next one?
Amara, Amara, you have the slides. Do you want to share that? Those slides?
Just a second.
Who is presenting now?
What I know is that Meher, Iram, and two other people wanted to present, but if they are not here, anyone can present.
I'm there. Sunanda.
Okay.
Sunanda, yeah, go ahead. Okay, we'll share the scenario.
I shared the scenario. You can have now 2 minutes to go through the scenario. Your time starts now.
Unmute.
Okay.
Amara, you can go through those patient instructions.
Do I have one more slide?
No, only this much information is given.
Okay. Okay.
Your time has for 2 minutes has been over. So Amara is going to act as simulated patient.
Okay.
So once Amara, are you ready? Amara?
Oh, sorry, I was mute. I had muted myself. Yes, I'm ready.
Okay. Your time start now, so you can start your case.
Okay. Hello, I'm Dr. Sunanda, one of the doctors in the Gynae clinic today. Can I confirm your name and age, please?
Yeah, my name is Rachel Sawyer and I'm 38.
How do you like me to call you?
Rachel is fine.
Okay, Rachel, I could see that you are here today because you had some issues with your periods and you are here to discuss further. Is that right?
Yeah.
Okay, Rachel, as I'm meeting you for the first time, is it okay if I ask you a few questions and then we can make a safe plan for your condition?
Sure, yeah, doctor. Thank you.
Rachel, do you have any other concerns in this consultation?
No, I am extremely fed up with my periods. This is the only problem and I really want to fix it. I'm very upset.
Okay. I could see that you are really upset and you are worried. Let me, as a team, we are here to help you. So, Rachel, can you tell me about your periods?
Yes, my periods are so heavy that I am extremely fed up. I am taking off from my work these days, and I have spoken to my GP a few times about that. They have given me some medicines, but it's not working. Yes, they are very heavy.
Mm-hmm. Are you taking any medications to control that?
Yeah, so my GP gave me some medicines, which are some contraceptive pills, I think. Yeah, but
Mhm.
they haven't worked for me. And then they tried to change the pill as well, but that was the same. And I don't want to take the pill now because it's not working for me. Periods are getting
Mhm.
heavier and heavier, and yeah, so that's not working. And it's a useless exercise to take a pill every day. I'm really worried.
Since how long you have started this medication?
Yeah, so I have stopped taking the pill since last year.
Okay. And do you get any other problems along with the periods, like acne or hair growth?
Oh yeah, yeah. So my hair growth is much more on my chin, and
Mhm.
I have to get it removed very frequently now. Yeah, and also my upper lip as well. I have noticed that the hair are a bit thick as well. Is it related?
Yeah, it is related, but let me explain to you. If you don't mind, I would like to ask few more questions.
Yeah, sure, yeah.
Okay, and a few questions regarding your sexual health. I would like to ask, if you don't mind.
Yeah, sure. Yeah, go ahead.
Rachel, are you sexually active at the moment?
Not at the moment. Actually, I wanted to try to be pregnant. I was trying to be pregnant
Mhm.
for at least 2 years, and then
Okay.
we were living very happily. But then my partner, he left me, and I don't know what happened, and he's with someone else. That was really heartbreaking for me, and yeah. So I wanted to have a baby, but he left me. I still want to have a baby, but I haven't found anyone suitable for me up till now.
Rachel, I'm really sorry. You do have a difficult time right now. Let me address your health. Then we'll think about planning for your pregnancy as well. Okay?
Yeah, thanks very much. Yeah.
Yeah. And did you had any sexually shared infections treatment in the past?
No, no.
Okay. When was your last menstrual period?
Uh, my periods are actually very irregular because I may bleed for 7 days, and sometimes I bleed for 21 days, and sometimes
Okay.
it's after 3 weeks, and sometimes it's after 2.5 months. So I don't exactly remember. I can tell you using my app that I have on my phone. But I'm not sure when I had my periods. Yeah, so that's very irregular.
Okay, and so I would like to see that so that it will help me to make a plan. And Rachel, are you medically fit and fine?
Yeah, otherwise I'm okay, but I can recall that my GP did an ultrasound and some hormonal tests, and he said that probably I have got a PCOS.
Okay, okay. Since when he was diagnosed this PCOS, did you remember?
Yeah, I think it was 4 years back when they suggested some pills. Yeah,
Okay, okay. And any allergies?
no allergies, no.
Okay. And do you know your weight to height ratio?
Yeah, it's 38.
And any family history of concerns you have to discuss with me today?
No, family is okay. Yeah,
Okay. Rachel, do you smoke?
I do. Yeah,
How many in a day?
one or two, not much. Yeah,
Okay. And do you take alcohol? Do you take any IV drug use?
no, no.
And what do you do for your living, Rachel?
I'm a solicitor.
Okay. Is these symptoms also affecting your quality of life at work?
Yeah, because I do private work and I have to take off so many times, so it's really affecting my finances as well. Yeah, so I'm really upset. Yeah, that's why I want to fix it.
Rachel, I'm really sorry. I could see that really it's a difficult time for you. If you wish, I can put you to a counselor. These are the experts who will talk with you, and they will you feel better if you talk with them, and they will make you to
Mm.
cope up with the situation. What
Mm.
is your thoughts about that?
Yeah. Thank you very much. Yeah, that will be helpful.
Okay. Yeah. And you said that your partner is not quite not with you right now. Whom do you live with right now, Rachel?
I live independently. Yeah.
Okay. And I would like to examine you in the presence of chaperone. I would like to check your blood pressure, temperature, and right now, then I would like to see, you said some hair growth. I would like to check the general well-being and the acne or hair growth. Now,
Okay.
coming to your condition, what information I have collected, then I would like to see the reports what your GP has done, so that is it the hormone reports what he has done?
Yeah.
Okay. So putting all together, I do have a suspicion that you are having, and you said that you are PCOS patient.
Yeah.
So this is a condition where it is going to affect the periods. Are you aware of the consequences of PCOS?
Not really. Can you tell me?
Yes, definitely. So what happens every month, there is release of the egg from the ovary. Ovary are the bag of the structures which have the egg producing structures in the body. So once there is hormonal imbalance, the brain also produces some of the hormones which affect the ovaries to release the egg. Because of this imbalance, the eggs are not released on time every month. And second thing is that there is increased insulin in the body which does not utilize in the body, so it blocks and it causes it blocks the insulin entry into the cells.
Mm-hmm.
And I could see that your weight to height ratio is also on the higher side. Because of this as well, the periods are quite irregular and it leads to this condition that is PCOS. Rachel, are you with me?
Yeah. Thank you. Yeah.
Yeah, because of this imbalance hormone, there is a formation of like acne and excessive hair growth and oily skin as well. So I would I would recommend that ultrasound has to be done so that we can see how the eggs are producing in each month.
Mm.
Okay.
Okay. Yeah. Doctor, can I,
Now,
because I am 38, so I want to have a baby now. So I hope that I will find my partner very soon. So I would like to have a baby. And last time they said that because we tried for 2 years, they said that I would IVF. So
okay.
it's possible for me to have IVF once you treat my periods.
Yeah, definitely. Once the periods are regularized, there are chances that the baby can be there are chances that you can have a baby. But let me put from your side what you can do, from our side what we can do to have this condition to be corrected. So you can change your lifestyle. I would suggest some balanced diet and exercise with a physiotherapist, so that your weight will be coming down, because there are health issues when the weight to height ratio is on the higher side.
Time
Invariably
up.
it should be 18. Okay.
Time up.
But you can continue. Yeah.
You can continue.
Invariably, okay, yeah, thank you. Invariably it will be 18 to 25. When it is more than 30, definitely it has effect on the fertility issues. So these things you can do. And you do said me that you are smoking, so if you wish I can put you to fertility this stop smoking services. So definitely smoking also do have effect on the fertility. So if you do all these things, about 5 out of 100 people will get regularization of the menstrual cycle. Then there are chances that you will produce eggs, and chances of pregnancy is also good. Then if that doesn't work, then we will recommend to start a medication which will help to produce the eggs. These are called ovulation induction drugs. So the first line drug usually we start is a clomiphene citrate.
Okay.
Are you with me, Rachel?
Yeah.
So sometimes this medication causes some amount of vomiting, and we give anti-sickness medicines. Another option is that we can start with the injections, but that all will be done in the second line with a team of nurses doctors involved in your care, a fertility doctor, my consultant, and a special nurse and a physiotherapist. As I said, like a dietitian also will help you. First, I would suggest you to reduce the weight
Okay.
and change your lifestyle, so that it is going to help. If this doesn't work, then I would like to discuss further management options.
Okay. Yeah, that's fine. Yeah.
I think I should
Okay.
intervene because now the station is going to a totally different direction. Um, First of all, just what do you think yourself how you did this station?
Me? Yeah,
Yeah,
I was not prepared. I was not prepared.
but you did well at some aspects, but some needed little of brushing. Um, so the thing is that this station was taken from one of the textbook that you do for your case scenarios. And therefore, because we keep those scenarios that are in the books so that you can feel confident and you can speak up. And what I think that someone who is appearing might have gone through this station. You did it well in a way that you was confident, you was fluent, and you touched some of the things that are really very important. For example, the concern of the patient. You get the idea that what the patient is going through, and also you in between you also address that what she is expecting. But at the end of the station, it was going totally to the different direction. Um, we will just go through the scenario first. That what I was I posted in this meeting, that what the case scenario is. So the thing is that the scenario was that you are in gynae clinic, so you should first thing come in mind that you are in gynae clinic, so some gynecological problem. It is not in fertility clinic. Okay. Age of the patient was given, and it was clearly written that patient is having heavy irregular period. So it should click in your mind that this is gynae problem, and most likely HMB. HMB is very diverse. It comes in very different ways, and it really give you hard time if you do not channelize it properly. So from these 2-3 lines, you have to make your mind that where I am going, and then the patient will direct you that where you have to go. So from these 2 lines, you can see that heavy irregular period. Her BMI was 42, and she was a diagnosed case of PCOS. Your task was to take history and examination investigations and make a plan. And only 10 minutes were given. When you started very well. You are asked, when the patient was saying that she has already taken some medicine, you ask again, are you taking any medicine? It wasted your full 10 seconds that you ask the same question when patients say that I have tried many medicine. So just prompt at that time what medicine you are on or what medicine you have tried. So it will save your time. So you can just ask her rather than making another question for the medicine separately. When you ask about any problem, other problems she told you about hair growth and acne, that was fine. About asking for the sexual health, you ask many times, if you don't mind, can I ask you? So these are something very casual here to ask about the sexual health. So just be quick. If you don't mind, I have some question about how is your sexual health? Is everything okay? Any infections in like chlamydia or gonorrhea in the past? They all know these things, and they don't mind if you just say in the start that I'm going to ask these questions. She also like there was a bit we know the station was more of about the period, so you ask about the last menstrual period at the very in between. So if I am examiner, I might have a checklist to take, and I might have written that you have not asked LMP or you have not elaborated very well on the presenting complaint. So you have to focus first on the presenting complaint of the patient. Periods were heavy, irregular. Just take a bit of history on that and then start the other history and come to concerns and expectations as well. You was empathic. That was good when she said that she was trying to get pregnant for a while. So that was a good thing. When patient was a bit sluttering that I was diagnosed something like PCOS. So if I am a layman examiner, I was thinking that patient is struggling to find out what she has and she don't know. So you should take like her words and say that it is polycystic disease of ovarian syndrome. So we will talk about it. It is called like this. So just help your patient. It will give layman's examiner numbers to you that you have here really seen that your patient is struggling at that moment. BMI was already given, so you asked it again. It is just like wasting a bit of your information gathering time. When smoking was asked, she told 1 to 2 cigarettes per day. I always, it is a general way. We usually suggest that we should address smoking on the same time. Otherwise, we forget or examiner will forget that he or she has to give us marks on that. So address on that, because even if she was taking 1 to 2, she do smoke and it do have effect. You use the term IV drug use, so it was jargon, which is against like patient safety issue. You should not use IV drug user term, and it is also a layman examiner will get provoked that you are stigmatizing her of being a IV drug user. You asked about quality of life. She already was telling many times that it is really disturbed. You can summarize it in a way that I can see it is really affecting your quality of life, but don't spend time again and again, because this is your key or your information gathering list. You have a question. If you have said was, examiner will definitely click on that you have asked this question or you have addressed this question. You took about 6 minutes and 15 seconds on information gathering. That was quite a bit longer than expected because it was a very diverse station as well. And we are still on information gathering. So in information gathering, what you have missed was that heavy periods, how long, since birth, since you have started menarche, or since how many years it is. Have you tried anything? This you have asked. Is there any pain with that? Only pain with the periods, or it is also when you are having sex? Okay. And thereafter you come, is the period in between the periods you are also having any bleeding, like you are ruling out intermenstrual bleeding, or you are ruling out any postcoital bleeding as well? Thereafter, you come to the point of any pregnancies before. She is trying for to get pregnant, but she may have any terminations when she was in her early hoods, so or as a teenager. So just click that box of previous obstetrical history, asking any previous pregnancies, and what she has tried for getting pregnant, and she was saying that the partner has left. You synthesize on that. That was a good point as well. You have asked about allergies and social, that are the good point you have done. When you come to the next point of examination, you say that I will check your general well-being, blood pressure and temperature, but why not to have a abdominal examination and speculum examination, because that was more concerned when we see a gynecological patient. And in my key, I was to tell you when you was having those examination, but neither of the abdominal examination nor the vaginal examination was done. So then comes the investigation. Although you tell that your GP has requested some of the investigation, but you just tell again here in a very brief line that usually is patient who have a bleeding problem with the periods. We do hormonal analysis and some other tests to confirm that what's going on. So patient examiner know that you are doing full blood count, you are doing hormonal analysis for this patient. So he will just tick that you have done biochemical test, and then you come to that what radiological investigation you are doing. So in this book, the key shows that there was examination that you explain to the patient that you are going to have a transvaginal scan rather than just an ultrasound, because they say that high BMI, and this is what you have to tell the patient, that I'm going to have a scan that we would prefer to have a vaginal scan rather than abdominal scan, because it has more sensitivity, and especially in your case or someone who is high BMI, where it is important that we rule out any ovarian or uterine pathology and see any bulky uterus as well. So this is how the key was made for this patient. There was also a number for endometrial sampling, because any patient who is high BMI, PCOS, or nulliparous and age of 38, endometrial sampling do have numbers for that. And it is important to rule out any endometrial pathology at that time. So that was missed. And thereafter, I think we just take the scenario to the infertility. For any case, if we are going to go through the communication with the patient, you did very well. A bit of trimming over there is needed, but then go to the communication with the colleagues, and you should say that I will discuss your case with my consultant and see that if we can involve the endocrinologist, our exercise staff are there, or the physiotherapist is there who will guide you through the supervised exercise program, because I know it might be a challenge for you to reduce the weight with having so much bleeding problem. So you can show the examiner that you are going to involve a couple of colleagues. So your communication with colleagues will be ticked that you have done that bit. And thereafter starts the management plan. And the management plan, I know HMB is very diverse. So if you will address a couple of things like smoking, weight reduction, progesterone in view of her polycystic ovarian syndromes, that is fine. But if you have time, you should explain to her that these Mirena coil are something that we can also offer. And if she's trying to get pregnant, whenever she's there, we can offer her some medicine that can help her to have babies while having the control of her bleeding as well, in the form of progesterone tablets to have withdrawal bleeding. So this is how examiner also know that covering HMB in 10 minutes is a challenge, but they just want to see that how quickly and how quickly you grasp that which HMB we are treating, and so that how you are going to reach towards the management plan. If you cover the safety points, you did till the initial bit of management, and you know that which management way you are going, you will pass this station. Any comments, Amara?
Thank you so much, Melissa. So well. I don't have much to say, to be very honest. Yeah, so as you said, that in terms of investigation, in addition to the PCOS investigations, when she has said obviously chasing her hormones and everything, because she's been bleeding irregularly for quite some time. So it's important to make sure that she's not anemic, very basic thing. But yeah, so that's one thing. And otherwise, I mean, you have told everything actually. Thank you so much for coming up, Sananda. You are a very good doctor. You present very well in the group as well, and you can do it easily because it's very easy to get B track. So that's why this is a very common scenario, and HMB is not difficult at all, but see how challenging it can be. Yeah, so there are a few forms in which they can give you HMB scenarios in the exam. I remember this was one of the cases in an RCOG course that I attended, and again, every candidate was a different aspect of this, but every candidate was focusing on, the fertility bit, and it's very important to address her weight and obviously this bleeding problem at that stage. Yeah, so it's very easy to get detracked in such scenarios. Yeah, so otherwise you tried. but it was not easy. Yeah.
I would say.
Dr. Amara,
Mhm. You asked a question.
Yeah, Iram.
Iram here. Yeah, I want to say something.
Yeah.
Yeah, Dr. Sunanda, it was a really good session, and Dr. Munaza, thank you very much for such a detailed feedback. One thing is really important in this patient, we may need to address the high risk of these long-term implications of PCOS.
Yes.
If it's really important safety point as well,
Exactly. Yeah.
cardiovascular risks and all that.
Exactly. Yeah. Thank you so much for adding that. That's true. And the thing
Thank
is
you.
that if you time your history, I was looking at the clock on my laptop as well. I think it was nearly 7 minutes that she was still taking history. And especially when the patient is telling you a lot of things, that she's telling you about periods and her partner, and she seems a bit depressed as well. So if you structure your history, then it can become easy, because exam will be like this. Yeah. So then you can say that because you have PCOS, so what we can discuss is you can actually divide. When this is what I tell in the group all the time. If you set your agenda or make up a small key in your mind that, okay, so this is PCOS and this is heavy menstrual bleeding, and she has got a raised BMI. So I have to discuss PCOS, her period. I have to discuss her raised BMI. I have to discuss immediate effects of PCOS, long-term effects of PCOS, and fertility. So these are the things. Now you can see what are her concerns at present. At that stage, she wanted to conceive, but that was not the presenting complaint. That was not the concern at that stage. That would be a concern later on when she will find a partner and she will have her period sorted, and her quality of life and finances, everything is being affected by that. So once that is sorted, that is the immediate issue. Okay. So you will address that. Number one, weight, as you said, I will refer you to the dietitian and some exercise groups. And then if you can try losing your weight and things like that. And then obviously, as Munaza said, when they say that I smoked, then address it there, and then otherwise you will forget. Yeah. So if you divide in these things, then you may be able to cover the long-term effects at the same time. Thanks, Iram. Yeah. I think we can move on to the next one, because we are it's already 12:30. Okay.
I would just say that there are a couple of case scenarios that can come on the Gynae module. You all know about this, but it is really a diverse module to cover. I would suggest that if we can just, when you are practicing with your colleague, just go through these bits so that you know that these are some of the things that can come, and these are the resources that can come. Some of the patient with HMB can direct you to the ablation or uterine artery embolism. So these are the way the patient will direct you that what specific type of management she want to go ahead. So don't get annoyed, just address what she's asking and you will pass the station, because there are a lot of things on HMB. And the other thing is that when in this specific scenario, when the patient asks about, can I have IVF? So since you know that it is an HMB case, however, if patient asks, just tell her that just bits of things that at BMI 40 do not come on infertility until or unless they drop their weight to 35. And if there is no other reason to be infertile, treating PCOS has very good result on future pregnancies. So let's address this issue. And if you did not get pregnant, we can refer you to the fertility clinic once your weight is less than 35. Because getting a funded IVF cycle in UK is really a challenge. So we cannot reassure patients just like that, that you can go ahead with the IVF cycle. This cannot be just address the general and know the general principle that BMI 40 will not fit into IVF cycle or IVF treatment in UK. So if you tell that, patient will know that you know a bit of the IVF or infertility things that are going on in UK. Okay.
Ma'am, I joined late.
Also on
Can we advise bariatric surgery, ma'am?
if she don't want to get pregnant, we can advise on Mirena. So it is something that is for the treatment of HMB you can give to PCOS patients.
She's asking about bariatric surgery. Yes, so we will not advise her on bariatric surgery. We will refer her. Okay. Her BMI is 42. She can
Okay,
try
ma'am.
losing the weight. First of all, she needs to, go through the basic steps first, and then she can move on to the other ones. Yes.
I will stop sharing, and Amara, you can go ahead with your case.
Okay. Who is the next candidate? Sorry, I'm just going back for a minute. Okay. Who is the next candidate who wants to present?
Dr. Amara, thank you so much. And Dr. Mona also. Yeah.
Thank you.
Welcome, well done. Thank you. Who wanted to present the next case? It was Meher and one other person. I don't know. If they're not here, Sadia, do you want to take it? Sadia Aziz?
Can I, ma'am? If nobody is available, please take me.
Okay. There are a few people who asked me, sorry. Yeah, so I'll see if one of them is there. Then otherwise I'll give it to you. It's fine.
Okay. Okay, ma'am.
Nobody seems to be very keen. Okay. More people want to listen, but it's a good thing to come forward and yeah, okay. I think you can take it.
Yes, ma'am. Thank you.
Okay, so this is the scenario.
Ma'am, I'm not able to see.
Can you see my screen?
I'm able to see, ma'am. But
It
the
is
body
not projecting, Amara. You share your screen. We can see that the presentation is going on over there, but it is very.
Okay.
Yes, ma'am.
It is, yeah.
No, not yet. Yeah.
Yes, ma'am.
This is the scenario. Okay, you can start now, please.
Hello, I am Dr. Manikam, the doctor in charge of the labor ward. May I confirm your name and age, please?
Yeah, I'm Selena Wilson. I'm 22.
Is this a spontaneous delivery or induced, Salina?
I was in the midwifery unit, and they have moved me down because my baby hasn't delivered. Yeah.
if you feel, I will examine you with my hand to find whether you are having any contraction or pain. When it is less, I will ask you some more questions.
Okay.
Tell me
Yeah.
that.
Okay. Okay. At the moment, yeah, it's easing off. It's fine.
I want to go through your notes also.
Okay.
Have they given any pain relief for you? Have you been given any injection on the back? No, it will not be available there. Do you want to have a pain relief here? I will inform the anesthesia doctor, that is the pain doctor. He will come and give you an injection at the back so that you will have good pain relief.
I had some gas in air. I was using some gas in air. Can I have some gas in air, please?
If it is okay, if it is adequate, you can continue it. If this is, have you ever been pregnant before?
This is my first pregnancy. Yeah. And everything has been normal, no problems in this pregnancy. But now, I don't know why this baby is not delivered. Yeah, I'm really worried. Yeah.
I will ask the staff nurse to record the blood pressure, heart rate and temperature, and I will, with your consent, in terms of Catherine, I want to examine you, the tummy, to find out the CTG is a normal now. That is the daily heart rate is normal now. So I want to examine your tummy whether this one head has been entered inside the pelvis.
Okay.
Or it is down.
How
Whether
will
it
you?
is felt in the abdomen, I felt in the tummy. I will see that. Then I want to do an internal examination.
Okay.
In a slide. You see that already it has been written in your notes that it has been fully dilated. So now you are in the second stage and you are pushing for the past 2 hours. So,
Monica, please speak. Monica, I'm sorry, please speak loud. I can't hear you properly. It's breaking as well.
okay, ma'am. And this is your first pregnancy. You have already pushed for 2 hours. So it is better to undergo.
I'm having a contraction. Sorry.
To give you pain relief.
I'm having a contraction. Sorry.
I'll ask my labor ward coordinator to inform my consultant and the anesthetist, and we'll make everything ready for your instrumental delivery. I think you may need instrumental delivery because the baby has passed this.
What do you want to do? Please do what do you want to do? What do you want to do now? Yeah, it's easing off.
We will give you the medication over the back. The anesthetist doctor, the pain doctor has come. He'll give you that, and you'll be, if you consent, we'll go for instrumental delivery. That is, we'll apply.
What is instrumental delivery, doctor? I want my baby out. I'm extremely tired.
The baby will be brought out with the application of an instrument called forceps. Under epidural anesthesia, the private parts will be cleaned, and your baby will be
forceps, doctor? I don't want forceps. Yeah, my friend had forceps. Her baby was ill, and the baby was in the hospital for so long. I don't want that. Yeah. So, okay.
There is another option. My consultant has come also. She is also examining you. And if you're not willing for forceps, the other one is vacuum.
Is there a problem? Is there a problem?
Yeah, already you have been sitting for 2 hours. You are very tired, and the baby is normal now, but the baby has passed meconium, and if you wait for longer, the baby will have to be kept in the special baby unit. For that only I am telling you, and we'll be giving you adequate pain relief. Do you have any allergy to any medication?
I don't have any allergies, but I just want to get this baby out. But I'm worried about this forceps. Is there any other thing that you can help me?
That is, you can use the cup-like, plastic cup-like thing will be applied over the head of the baby, and it will be pulled with the suction. That can also be done.
Okay. So
And
what do you think is better? Monica, I'm just trying to
yeah,
help you look at the examination findings on the screen, please.
uh, force of delivery will be
Monica,
giving you.
sorry.
Uh, oh,
Look
okay.
at the
Oh,
look.
I'm seeing, ma'am. CTHT
Okay.
is not palpable abdominally.
Yeah.
At the vertex vaginal examination, well flexed fetal head, direct of the anterior position, +1 station, taper +1, no molding, presenting with maternal pushing approach. So this is a good sign for use of instrumental delivery. If the patient is accepting, I'll go for instrumental delivery. Forceps will be associated with perineal trauma. Advantage will if only catheter is only one plus. We can use even ventral.
Okay. So
Consultant will decide that whichever is. Yeah, ma'am.
okay, so, doctor. So do you want to do it now? I just want some pain relief, please. Yeah.
Pain relief you are providing. You give your consent, and as your first pregnancy, I mean, this is your first delivery. We'll be shifting you to the theater, and we'll be doing this. It'll be better
Okay.
for you, as the baby is just below the bone of the pelvic bone. We call it as spine. So it's better. You'll be shifted to the theater, and we have to finish the written consent. Will be someone will be writing, and you are willing, and we'll talk to your partner also. It is good for the baby and for you also. My consultant is very experienced, and the baby doctor also we have informed they will be coming now. They are arriving, and all the baby resuscitation things are also available. So you are
Okay.
being shifted to the theater. You are accepting. We are
Ah,
trying for them.
I'm having a contraction. I'm having a contraction. Hold on.
Yeah.
Sorry. Yeah. Okay. Yeah, we can go to the theater now. But just let me know that will my baby will be okay?
Yeah, the CTG is normal. The fetal heart racing is normal. Fetal heart is
What is CT?
normal.
What?
CTG means the fetal heart. We have tied one thing around your belly, no, that is recording the fetal heart rate. So fetal heartbeat is normal. So
Okay.
and this will be a quick procedure, so you can have it. If it is necessary, if the pain has not settled down, we'll give pudendal block also. That is injection of the numbing agent to the nerve at the bottom of your birth passage, and we'll be giving one antibody injection also. Sorry, antibiotic injection also. If you are not allergic.
Okay,
After
doctor.
this,
I'm also scared. I heard that when you use these forceps or whatever you want to do, whenever you use some instruments, then women can have cuts down below. Yeah. Will I have a cut as
yeah,
well?
yeah, you have. We'll be protecting the when the head is coming down and they are projecting at the outlet. I mean, at the outer part of the vagina, that is the bottom. When it is coming out and it's difficult to come out, we'll be protecting the bottom portion with the one hand, and we'll be giving a cut at the on the right side, and that will be helping the baby also to come out easily, and that will be sutured as you are already under pain relief. It can be sutured, and it will be cared well, and you are being given antibiotics. No, so it will heal also well. And after the baby is being delivered, the doctor, this baby doctor, and the team will be looking after the baby, and the cord blood, that is the blood in the umbilical cord of the baby, will be sent for test, and we will be delivering the after
Okay.
birth, after it
All
is separated back.
very scary. I'm very scared. Okay. Yeah. So are we going to theater now?
Yeah, everybody is a well-trained and qualified person, so you need not worry. And your that pain relief is also being provided and continued. Do not worry. We are here to help you.
Time is up. Time
Yeah,
is up.
thank you.
Yes.
Thank you, ma'am.
Okay. What do you think about this yourself? How did it go?
Ma'am, I have not completed, ma'am. I should have explained about the repair of the episiotomy in the theater under anesthesia, under good light. I should have told. And as she's not under epidural, I have told that she should be delivered with instrument. And as she is in +1 station, I asked, I told that she has to be shifted to the theatre for delivery. And she is a primary, no ma'am, that's why I told like that. And I have asked for her consent also. And I have involved the consultant, specialist advice, and the labor ward coordinator. And everything will be available in the operation theatre also, no ma'am. So the future materials will be provided.
Okay.
They have told about, yes.
Okay. Yeah. Thank you. Thank you. You can mute yourself. Okay. Thank you very much. Thanks for coming up. Thanks. Okay. Yeah. Any comments, guys? Iram, Noreen, Sunanda, and I can see 16 others, but can't see your names. So anyone who would like to give a feedback. It was not an easy scenario. I understand that. Okay. Anybody? Sunanda, do you want to say something?
Amara, you asked me.
Sunanda.
Yeah, hello. Hello.
Hi. Yes. Sunanda, do you want to say something about
Yeah, actually, yeah. So patient was in 2nd stage of labor, and it has been shifted from midwifery unit to alongside midwifery unit to delivery suite. So I think we couldn't hear actually Dr. Manikam's voice in between. It was very low.
Sorry, ma'am. I'll shout.
Yeah.
Be
No,
loud,
no.
clear, Aksha.
Otherwise, it's fine because it's a tough station.
I'm just trying to,
And
I'm
yes.
trying to end up the presentation, sorry. Okay, yeah, you just keep on talking, yeah.
Hello.
Yeah. Yes, I can listen to you,
Yeah.
Sunanda.
So she was quite, yeah, she was quite sympathetic to the patient, what all questions she asked. And I could see that she told some consultant will come and examine you. So first we have to see, we have to examine and then make a plan. If patient is not agreeing, that means we have to take help of consultant. And she did well. Only few points like I thought she was not going for the management.
Yeah, sorry. Can I ask you, why do you think that the patient was scared and she didn't agree? Can you think of something?
Maybe, I don't know, because I couldn't hear in between.
Okay.
She is worried
Dr.
about
Amara, yeah.
perineal here and some of respect to that pain and any problem to the baby.
Her friend has some bad outcome, I guess. That was the reason.
Yes. Good. Yeah.
Her worries and anxieties may need to be addressed more.
Good. Yeah. Okay.
And she must be reassured that I understand the previous bad outcome of your friend, but maybe there must be some reason behind there. So reassurance may need to be provided, I guess.
Yeah, exactly. Well done. Okay. Shazia Durrani, are you here? Okay, I think she's, I don't know if she's able to listen to me or not. Noreen, do you want to say something? Okay, so let me.
Sorry, Dr. Amara, I was a little busy, so I couldn't hear completely. But what I understand that she should have given the pause or when patient she was having the contractions. And apart from that, when she told that, oh, I don't want to go for forceps delivery. So need to tell that whatever your wishes, we will definitely respect, and we are not going to do anything which you don't want. And I think she told like this, me and my team are here to help you in this situation. And apart from that, that should ask that, may I know what are the concerns behind that? So I think there was some friend problem, so that need to be and going to examine and both the options of the instrumental delivery and plus the cesarean sections to be given, and this is patient choice and pros and cons to be addressed for both the procedures. So it is up to the patient, whatever she chooses. So that's it. I think I'm sorry, I couldn't hear completely.
No, but your comment is really good. Thank you. Okay, so first of all, listen very carefully, everyone. So you are in delivery suite and you are ST5. Okay, so which means this thing that I'm just going to tell you now will be very helpful for you for all the labor ward scenarios, but particularly for this one. So when you are on delivery suite, you are an ST5. ST5 is a senior doctor. ST5 is a middle grade senior doctor. Okay, so it means that they have done 5 years of training. This is their 5th year of training. They will pass MRCOG and they will be senior registrars. Okay, so a lift out forceps or a ventouse delivery is a skill that is learned at ST2 and they are signed off and then they are promoted to the ST3. Okay, so it's not something that they will call their consultant for. Number one, this is I'm not criticizing. This is just to tell you how the system works. Okay, so they are signed off and they are quite competent themselves in doing this, and they can counsel the patient because this patient is a low risk patient. Okay, patients do have concerns, so we are there to address their concerns and help them. Okay, so now the patient has come from an alongside midwifery unit, which means that is a low risk pregnancy. She was not a high risk patient, but the only thing is that she hasn't delivered. So she hasn't delivered, so there can be 2 problems. Okay, rather 3 problems. We have to see the passage power in the passenger, the usual thing. Okay, keeping that in your mind, you will obviously approach the patient. So my understanding in this scenario will be that that's a low risk pregnancy. She's a young girl, 22 years. Parity is not mentioned, but that's all right. You can ask the questions like, I will review your history, I will go through your notes, ultrasound scans to see how big the baby is. And if after that, is it okay if I have a feel of your tummy? Okay, because you have to check if the fetal head is palpable or not. And then I would like to do a vaginal examination. Okay, is it okay to do a vaginal examination? I can see that you are in a lot of pain. Whenever she has a contraction, please stop talking. Don't talk at that stage. Give her a break. She will give you time, because it's just to see how you communicate with the patient.
After examination and things, you can say that don't worry, we are here. The communication with patient, you did not score points because you did not tell that what's going on. You should have explained that you are fully dilated and you are really pushing fantastic, but the things are that if someone who is going ahead with pushing more than 2 hours, the chances are that you can get exhausted. Sometimes the baby can get exhausted. At the moment, the baby is doing fine because the trace of the baby is normal at the moment. Reassure and warn, reassure and warn, but because you are going to do an intervention. Thereafter, you say that, and even if we leave you pushing for a long time, it is going to increase the chances of having excessive bleeding once you deliver the baby. So patient knows that why you are intervening, why you are just on the way of her delivery plan. If you will do it that way, it will gain your marks for communication with the patient. Then comes communication with the colleague. So you don't have to call the consultant to examine again, but you can say that I will examine and I will discuss with my consultant. If we are going to deliver in the room, that's fine. But if any patient in UK, you have to go to theatre, you have to inform your consultant. So this is why you have the delegation with your consultant, but not in that way that my consultant will examine, but you can say that I will discuss with my consultant and labor ward coordinator as well. So, and anesthetist, because she needs pain relief medicine at the moment as well. So this is your points for the communication with the colleague. When it comes to applied clinical knowledge, keeping in those information, there are 2 options that you have, like I either ventouse or forceps delivery. So there comes your applied clinical knowledge. You have to go to explain the patient risk and benefit of those, and thereafter you then direct her that I think it is +1 station for kiwi cup or what you can fail, after you have explained all the risk of kiwi. And the forceps can be more successful, but while we are doing this instrumental delivery, we need to give a small cut called episiotomy. Why you have to tell episiotomy? Because you want to get number from the examiner. You are telling patient that we need to give a small cut to facilitate the instrumental delivery. Called episiotomy is just to let this examiner know that your applied clinical knowledge is good. You mentioned about antibiotic. That was a good point. And the patient was, you told about that I need to take the consent. You know that consent taking is something that you have to tell in elaboration that there is something documents that we need to sign if we need to go to theatre, because this is how examiner is knowing that you know that if she need to go to theatre, she will be signing those papers, and these will be risk and benefit, and the proposed procedure will be written on that. This is how the things will go, and but otherwise you really did well. But these safety points and fluency of the station was missing in those things. From a layman point of view, I think that it might be difficult to give the numbers when you did not address the fears or the concern of the patient, and also while you are talking to the patient while she's in pain, and you do not develop a rapport by encouraging or appreciating her that she has reached to the full dilatation without any active intervention from the medical team. So these are the points from my side. Amara, do you want to discuss anything further?
I didn't, you said in the beginning, I could hear just the last bit. So I was just telling before I lost my connection that the system, see, everywhere in the world you are doing the same thing, okay? But you just need to understand the system. Because I was telling you that if you are an ST5 working on the delivery suite, you are one of the senior doctors who will be looking after the patient. So for everything, we don't need to call our consultant, but as Munaza said, that if you have any concerns or the patient is not agreeing, so that's why obviously you can offer them. But probably this will be the delivery that you will be doing, okay? So what you need to do is to build a rapport with the patient. So that was the problem there. Okay, I totally understand it's not an easy scenario, especially for overseas candidates, because now working here now, just now we are also used to it, but you know, the system over there is a little different. Yeah. So here you have to tell patients all options. So patient will come even at this stage and they will ask about their options, because if she's scared and her friend had a baby who had some problem after forceps delivery, we don't know what happened at that stage. So you can just reassure her that generally it's a safe option for you and your baby. I'm not very sure what happened with your friend, but I can tell you the risks and the benefits of this procedure and the other options, and then you can decide what you would like to do. Okay? At this stage, when the baby's head is in a favorable position, it's +1. It's in direct occipito-anterior. She just needs obviously help to deliver the baby. CTT is reassuring. Meconium doesn't matter if the CTT is reassuring. Okay.
Yes, ma'am.
And then, and obviously you have made a decision to deliver the baby. You are not leaving it. So you can tell her that, you know, after assessing you, I can say that this is a safe option for you or a recommendation from our side, but the other options can be waiting a little longer, which can make you and your baby tired, okay? But as your baby is happy and you are doing well, we can give you pain relief. So this is one option. I'm not encouraging, you know, this is not a recommendation, so I'm not encouraging, but this is what you need to tell them. And then the third option is going ahead with a cesarean section without trying, which is not a recommendation at that stage, because you have progressed so well in your labor. You're doing so well. You're pushing your baby down. So I can see a little bit of the baby's head when you push down. So that's really encouraging. So in my opinion, the recommended option will be to deliver your baby using forceps. Okay. Now, then at that stage, because the patient will be comfortable if you build up a rapport. Then she will ask you the pros and cons of the procedure. We couldn't reach at that stage. So then she will ask, is it safe for my, maybe I ask you, is it safe for my baby? What are the risks for me and what are the risks for my baby? So you can tell them that the babies can have marks of forceps or bruises on their face. It's generally a safe procedure for them. But very rarely babies can have more damage, like a bleed in the brain or something like that. So that's quite dreadful at that stage. But these are the things that we have to tell them, okay? And for you, sometimes when we are delivering the baby's head, we will be working together. You will be pushing, I will be gently pulling your baby, okay? We'll keep on talking. There will be a stage when your baby's head is very close to delivery, so I'll give you a small cut down there. And when your baby's head is coming, I may ask you to stop pushing so that we can prevent. You have to tell them about third-degree tear. You have to tell them about PPH, shoulder dystocia, okay? Because these are the known risks. And if women have third-degree tear or shoulder dystocia with with a bad outcome afterwards, that can be a source of litigation. So you have to cover yourself from that point of view. That's also very important from the point of view of documentation later on, but that's not part of this station, obviously. So to tell them that these are the risks, small risk of having tears going towards the back passage. Okay, we will try to prevent it, but this can happen. Okay, yeah. So I mean, these are the things that can happen. So you can tell them. And then, yeah, small risk of having bleeding, but we can give you some injections to contract the womb, take extra stitches, yeah, stuff like that. So this is how you will take it. Yes, so some, as Munaza said, you know, we have to tell them the risk, some reassurance, but we have to tell them the risk. And yes, just comfort her, make her comfortable. You took the right decision to take her to theater to make her more comfortable and then go ahead with the procedure because she was in pain, she's exhausted, and she probably won't be able to take that without more pain relief. Yes. Okay. Thank you so much, Monica, for coming up and taking this. Yeah.
Thank you, ma'am, for your time.
Do we want to do the last one? Hello?
Is there anyone who is willing, or we can put it to the next, whatever way you agree, Amara? I have no issues.
Ma'am, if there is nobody else, you can make use of me, ma'am.
Maybe we can call it a day and do it next time, yeah?
Okay. Yeah, I agree.
Okay. Yeah. So let's call it a day. Thank you so much, everyone, for participating. I'm sorry. I don't know. I never have electricity breakdown here, but today I had one, so I lost my connection in between. Yeah. So, yeah. So if you have any questions, any queries, you can share in the Telegram group. Okay.
Dr. Amara, I have a question. Hello.
Yeah.
Yeah. Actually, in this question, there was information gathering. So we need to ask about the blood group. We need to ask about any other surgeries. How do we ask in such circumstances?
Sorry. You can quickly ask her. It's fine. You can, but be very quick. Don't go in details of what is your blood. It doesn't matter at this stage what is her blood group. But yes, it matters whether there is any reservation to blood transfusion. So because in this scenario, basically it's more of a counseling station and addressing her concerns. But obviously it's important to do some information gathering. So you can ask her quickly, were there any problems in this pregnancy? Do you know your blood group and do you have any reservations with blood transfusion, any medical problems in the past, any allergies? Yeah, she asked about allergies, I think. Yeah.
Okay. So because she is transferred from the midwife unit, we cannot take it for granted that there was no risk factors at all for her, or do we have to sometimes ask questions? Because this is my question.
So
I informed you in the early that there are numbers for information gathering, and regardless of the numbers, when we normally in normal situation we see such patients, we usually go through all these informations, whether she was induced or a spontaneous labor, how are her pains, how is she still feeling the movements of the baby, any medical surgical problems, any previous pregnancies. So, but it should not be very long because basically they are checking your counseling and your communication. This is more predominantly a communication station rather than something like HMB, where you get a lot of information and a lot of chunk goes on information gathering. But important and safety points, you are going to take this patient for instrumental, blood group, and HP. If you will quickly go through, I will just make sure that what is your blood group and your last hemoglobin. Examiner will know. No, you cannot stay on that the patient is still in pain and you are going to delay the station just asking for something that is not going to give you any numbers when you are in actual scenario, you know.
And Aisha, that
Thank you again.
yeah, because you also asked that since the patient was transferred from the midwifery-led unit, does it mean that she is completely low risk? So low risk, and obviously we divide pregnancy in low risk and high risk. There is nothing as no risk. So low risk women who go to midwifery-led units can sometimes still have issues, but they are suitable and they fit into that criteria of going to the midwifery-led unit rather than delivery suite. Yes, so that's why we have to go through a little bit of history as well. And another thing is that, as I always tell in the group as well, that there are 5 domains that are to be tested, but you cannot draw lines between them, especially information gathering and patient safety. So unless you have got all the relevant information, you cannot pass the patient safety domain. Yeah, so that's important. Yeah, so but be very quick.
Thank you.
Yeah,
Thank
so
you. Thank you very much.
a funny thing that's coming in my mind. So I'm 100% sure you are not thinking about that, but obviously we are not going to follow the whole template of everything and ask about her smears and everything. That's not the thing, but the relevant things, they are important, and then you can ask, yes, in 1 or 2 minutes. Yes, thank you.
I would like to ask a suggestion from the team members that what do you suggest all the participants that how we can improve these sessions so that you can get the maximum benefit of these 2-3 hours when we are along with you? Any suggestion from the participants to improve our sessions?
Ma'am, can I ask something? Iram here.
Sure.
Thank you very much, Dr. Amara, Dr. Manazza, specifically taking out the time for arranging such a lovely this session. Even 3 to 4 thoda but bahut acha, something like that. So whenever you people put the scenarios and you give the feedbacks in that session, so it is highly, you know, it's one of the encouraging factors for us to practice more and more. And the more we practice, the more we will do better. That's what I think. Thank you so much.
Iram and all the participants, just one thing that when we started, it was very difficult even to come on the board and speak. But I really appreciate that you come on the board and you speak about all these scenarios, but do not take it too hard in a bad way that you did not perform it well because you are doing practice. It is a good thing that you do mistake here rather than doing in actual exam. But you are doing the best at the moment. This is something that I would say to all of you, and I will encourage all of you to present, because at this platform you can be corrected, but when you are in actual exam, obviously the thing is that you have to reappear, which we all of us don't want to reappear in exams again and again. And we can use these platforms to practice more, which I would suggest that some of the participants are really showing courage to come on and sit on the hot seat to present. But this is your own practice, and all of the candidates should come with the same spirit, because we do prepare the stations to have, but hopefully the next time, I think the more people will be agreeing to come to the hot seat and present. But thank you, Iram, for the comments. Anything you want to improve, just let us know in the chat box or on Telegram, and we will be taking consideration of these recommendations in our future.
And Dr. Amara, I would say some of the clinical governance cases, because we are not aware of so many things which are going in NHS, because we are overseas candidates. Some of the clinical governance or risk management, such stations, if you bring up, that would be much benefit to all of us, I believe.
Yes.
Okay,
Yes.
we will do that.
Yeah, that's also one of our focus points, because as we said, I don't know, Aisha, you have attended our previous ones or not, or you are in the group or not, but anyways, we always tell the candidates that since we appeared as overseas candidates and now we are working here, so we can see the difference, and we can tell that these things are not difficult, but for overseas candidates, we have got lots of knowledge. It's only about learning the system. So those are also very easy. We will make them very simple and easy for you, and that's our next focus. So hopefully in the next session that we will do whenever, we'll let you know in the group. So we will do some difficult sessions like those, yeah. Clinical governance.
Thank you so much. Thank you so much.
Yeah, no worries.
Thank you so much, Doctor, once again. Thank you very much. It was really nice to know you people. Thank you so much.
Yes, thank you. Take care. Take care, everyone. Thanks for
Thank
coming.
you, everyone. Thank you.